Good morning. How are you feeling? You feeling good? I do too. Beautiful day. A beautiful subject. My name is George Johnson, and I'm your facilitator for today. And what we'd like to do is welcome you and thank you for coming, and also thank the Sanford Burnham Research Medical Institute for these wonderful facilities. And they have other facilities right out the door and down the hallway about a quarter of a mile. And you'll find the restrooms there if you're in need. They're very gracious to provide these facilities, so let's keep it clean for them so when they come in Monday, it'll look like it did Friday night. And my role here is sort of to warm up the crew here and to give you a little preamble to our conference. Some of you have been here before and said, why does he keep doing this? Well, the reason is for the newcomers and for a new speaker. Of course, this is not an old speaker. This is the return of Dr. Lamb, so he's heard this before. But there are about 4 of us that have short-term memory loss and need to be refreshed. So that's the purpose of this kickoff. Here's the host. Here's 80 years of prostate cancer experience. Lyle is not with us today. He's in the hospital recovering from a heart procedure. And if you would like to sign a greeting card out in front, we'd appreciate that. And I know he would too. Next we have Gene Van Vliet, who's my boss, who makes this thing run. And we're very thankful for him and his constant attention to this program. Bill Manning is back there. He's manning the video camera. He has to have a camera. That's one of the features of each member. They have a specialty. Then we have John Tatsy. He's a webmaster, and he has some facial hair just to give him a distinguished look as a webmaster. Bob Keck. Bob Keck is the one that is qualified to be the librarian because he has to haul the big boxes of all those books and literature and DVDs that you'll want to purchase. And then Jim has a wonderful smile, so he's our greeter. And we still have people coming in. Grab a seat. Don't tell the fire marshal. We're almost up to his limit. So everyone is a volunteer. We get no salary, but we get wonderful benefits, being able to serve you and participate with you in our program. If you'd like to volunteer, just see me or Gene. Okay, one of the things here for our newcomers, did you all get a newcomer package? If you didn't get a newcomer package, wave to Jim. Okay, and the purpose of that is a really nifty information packet that you will benefit from reviewing. Tells you about the different treatments and our purpose and mission. And it also gives Gene a phone number to call you to welcome you aboard and see what services we might be able to provide and the questions we could answer for you. Now, what's the mission of this program, this activity? This is a support group. And we're here to help you become your own case manager. You have a busy doctor. He sees 3,000 patients and he maybe only has 10 minutes for you. So you have to be your own case manager. You should keep a notebook of all your lab reports. You should be getting a copy of every lab report and put it in that notebook. Keep a list of questions you want to ask him. Take that book with you. Let him see you write down the questions or answers. That shows you're disciplined and concerned about your situation. So you'll learn a lot how to become a case manager, but we're no substitute for your doctor. We're very patient-oriented. We get a lot of experience we'll share with you, but your doctor is the one that is the one you should seek guidance from. And so what you hear here is not to tell you what you should be doing, but maybe provide you some questions you should ask your doctor. And I think that's also true for our guest here. We're not here to give you medical advice to act on. It's to give you information so you are informed. We need your support to be able to support you, and we have some baskets here. These are small baskets, so we're looking for big bills. We're a nonprofit, and what we want to do is make sure that you don't have a guilt when you file your income tax next year. This is our last meeting, and you're saying, oh, I wish I'd given more so I could have a bigger deduction. So this is your opportunity. Who's in charge of our baskets here? Do we have a person that would volunteer and pick those baskets up and move them around? Well, I'd like them to go right up and down the aisle. They're right there. One for each row. Just send them on down and keep them going. Some of you may not have been to church that often to see how we do this. Okay. You know, we're in 3D, and you know what you have to pay for a 3D movie. And so we like big bills with zeros. Okay, keep those baskets going, dig deep. This is your last chance for deductions. Okay, what do we do with the money? We got a website. The website is changed every week because we got Dr. Snuffy Myers, who gives a mini lecture every week. That would be of interest to you. And it's got all kinds of information in it. And next we have DVDs. And these DVDs are only $10. Unlike PBS, you don't have to donate $250 to get a DVD. It's only $10, and we make a little profit off of that, which keeps our program going. We've also got some books and a number of things that somewhat unique to our group, that we have tremendous information for you, and we want you to access that. I'll give it a little plug in a minute. We have an outreach program, and we got cards for you to pick up and share with your friends, because a key part of the outreach program is, number one, all men should get a PSA test. Discount that task force, they're wrong. And because what's important here is early detection of prostate cancer, because by the time you get the symptoms, it may be too late. So you want to detect it before you have the symptoms, and that's what the PSA is for. Next, we have a newsletter. We have copies of it right here. It's got snappy new information and some old jokes in it, and I'm sure you'll want to read it. Get a copy on your way out. We have monthly meetings, except for next month. No meeting. Merry Christmas and a Happy New Year. Well, we got a full roster of speakers coming up, and we'll send you that out in a newsletter. Yep. Okay, I'd like to do a survey, and this is for the newcomers and for our speaker, a profile of the attendees. So I'm going to ask you to raise your hand. And so how many are here for the first time? Raise your hand. Look at that. Keep coming back, and you're welcome. I think you will benefit, and this is a good group of people, and we encourage spouses to come also. How many have been recently diagnosed within the last 6 months? So this is a new event for you. I share your concern. I went through this process myself. And how many have had prostate cancer for up to 1 year? Okay. How many have had prostate cancer up to 4 years? Okay. You see we have a young group here. And then 5 to 10 years. Look at that. You're still here, aren't you? Okay. 11 to 15. You're still here. How many has got more than 15 years? Who's got the longest? There. How many years now? 20. Can you beat that, 20? 24. Anybody higher? 22. Congratulations. Now, guess why they're here so long? Because they keep coming back here. And Bob's got all those years because he lifts those heavy boxes for how many years now? 20 years? Long time. So we appreciate your attendance, and keep that smile. Okay, now we're going to do a treatment survey. And some of you get to raise your hand very often. In fact, John in the back has had almost all these treatments, so he'll keep his hand up. It's not because he has memory loss, it's because he's done it all. Okay, how many have had surgery, prostate surgery of all kinds? Look at that. Okay, how many have had radiation? How many have had, are now on and initially on ADT without any other treatment? Let's see those hands. You see the growing trend we have here. More people on ADT, which is a good sign. The message is getting out. And congratulations to you to do that before jumping into evasive treatment. How many are on chemotherapy? Keep those hands up. Okay, there we go. We got about 5%. Pardon? Have had, and survived. Yes, right. Okay. Okay. I made a mistake here. On ADT hormone therapy, I was jumping to active surveillance. Let's do ADT hormone therapy, which is the subject of today's meeting. Hormone therapy, how many are on that? Okay, that's the subject. I'm on that, and a lot of us are on that because we've had recurrence and we have to get back on. Now I want to do active surveillance. How many are on active surveillance without any prior treatment? Okay, that's a continued trend for more of that. Stay on that. Okay, new treatments like cryo or HIFU, any on those things? Provenge. Provenge is going through bankruptcy, but they're still making the product and treating you people, so don't be concerned about that. There needs some refinancing. All right, recurrence. How many have had recurrence after the first treatment? That's kind of the name of the game, and what frequently it is, you go on ADT after recurrence. How many here are undecided about their next treatment? Okay, well, maybe we have some information here that will help you on that decision. Feel free to ask other members and members of our board here about what their experience has been. And we hope you get to establish a network. And what we do have for those who are undecided, every 3 months or every quarter, we have a networking effort where we gather people together by subject or treatment area and share experiences. So that's something you want to consider attending. What I'd like to do now is to do a survey on ADT. Okay, for those who are on or have had ADT, let's see, and this is for Dr. Lamb. How many have had, I hate the phrase, surgical castration? Anybody? That's the first way, really the only way of treating prostate cancer back in the 40s and 50s. How many have had that? Anybody?
Everybody's had it.
No, this is... Yeah. Okay, now how many have had, I hate the phrase, chemical castration? Okay, now that is ADT, and how many are on the injection, which we frequently called Lupron? How many are on that? I was on that. There's other treatments of injections like Trelstar, any other, on non-Lupron, other treatments. What have you had? Okay. Okay, I've had Trelstar. Okay. Okay. All right, now let's go to androgen pills, the pills, bicalutamide, known as Castrate. How many are on that? Or have had it, yeah. Have had it, look at that. I'm on it. Okay, now let's go to combined androgen blockage, CAB, where you take both Lupron and Castrate. How many have done that? Okay. Now another one is the opposite, that's called, I love the phrase here, anti-androgen monotherapy. In other words, you have no injections, you're just on Castrate. How many are on monotherapy? 1, 2, 3, 4. Okay, why so few? That's just taking Castadex. It's not been sent to trial by FDA. When they did the Castadex study, it was combined with Lupron. It is in common use in Europe, very effective. I'm on it. I couldn't take Lupron, and it works for me. Over there, they do 150 milligrams. What I'm taking is 50. So I have fewer side effects, and it works for me. My PSA is 0.2. But in some cases, the Europeans are a little ahead of the Americans, or their FDA equivalent are ahead of ours. So it's understandable why so few are on monotherapy. Maybe we'll hear some more about that. Intermittent androgen deprivation, IAD. How many of you have tried that or are on that? Okay. Bob, how long have you been on that?
19 years.
Okay. It worked for him. I was on it, and I'm thinking about whether I should go back on it. It's also called a holiday, where you stop taking it and your side effects or whatever diminish and you're feeling better, and then your PSA tends to gradually rise. And how long does it take yours to rise, Bob?
Well, lately, since I've added metformin, it's been 18 months so far to get from 0 something up to 2.
Okay, good. Maybe we'll hear about metformin too. All right, let's talk about another one that's taking finasteride or dutasteride, Proscar Abidart. How many are on that? I'm on that also. So that's another treatment, a supplement to that. And now we got some new treatments. I love the names for these things. We go from Lupron to Trelstar, that sounds like Star Wars type of thing, to Castadex and Abidart, which sounds like a computer software. And now we're into Zytiga and XTANDI. Zytiga, how many are on Zytiga? Okay, not very many, it's new. XTANDI, how many are on XTANDI? Okay. Zytiga sounds like a poisonous lizard. Watch out for the Zytigas. And we'll hear some more about those too. So I want to thank you for that survey, and good treatment to you.
You ask how many are castrate resistant?
Okay, that's a good question. How many are castrate resistant in that these things don't work for you?
Well, the Lupron worked, and then that's why I went on XTANDI and Zytiga.
Okay, but something's working for you on ADT.
Pulling it back, yeah.
Okay. How many are resistant to that, or these programs have failed? Raise your hand, please. Not that many. Okay, that's a good sign. All right, one more question. How many have had the opportunity to visit Dr. Lamb at Marina Del Rey? Look at that. You might be called the Lamb's Fan Club, okay? Great. So this concludes it. I'll turn it over to my boss, Gene.
Just quickly, as you probably noticed, and George mentioned briefly, that our president, Lyle LaRoche, had to have triple bypass surgery recently. I just had an email from his wife. She's communicating to me like twice a day. He's doing well. He's not out of ICU yet, but you know how Lyle is. He's going to bounce back. I thought it was interesting. In one of her communications, she said that as he was coming out, the nurse asked him to raise 2 fingers. I think I'll just leave it at that. I'm not going there. Okay. Anyhow, he's doing well. Please, he will be most pleased to receive these cards we have sitting out there. If you didn't sign them on the way in, please sign them. As soon as he's taking visitors, I'll get in to see him. Knowing Lyle, he really doesn't like to take visitors, as I didn't when I was in the hospital. So better when he gets home. But he'll know we're behind him. I did, 2 weeks ago, I did my annual donation mailing. I hope you didn't throw it away. but if you did, there's more envelopes out there that you can help fill up. I try to do this only once a year because I don't like to drive people nuts with us asking for money all the time. We get donations at each meeting, but it's pretty expensive to run this group with, especially with the advertising, which helps bring many of the people, although you people are equal to advertising and bringing people to the meetings. So keep the word going around about what we do here. Echo a little bit what George is talking about. As most of you know, that a couple of years ago, the Federal Commission says let's not do PSA testing anymore because it's causing overtreatment and horrible medical expenses. And that's true to some degree. And the problem with that is, if you don't do PSA testing, how are you ever going to know when you got it? And the urologists that I've been in touch with were telling me that already people are coming to them with more advanced cases of the disease, and that was predictable. I see a head shaking here. That had to happen. So tell all your friends that they need to do the testing, because their doctor, quite likely, your GP quite likely isn't automatically going to give you a PSA test like they used to do. You have to ask for it. So please help us get the word around on that, because unfortunately with our disease, you don't know it until it's way too late. Okay. Enough of that. I'll bring Dr. Lamb up to speak to us. You saw the show of hands. It's very simple. He's with a group called Prostate Oncology Specialists. If you have prostate cancer, why wouldn't you go to an oncologist that specializes in our disease? We don't have such a thing in San Diego. We have a lot of urologists, obviously, who deal with prostate cancer, but may not have the most up-to-date treatments knowledge that these people have. So without any further ado, bring Dr. Lamb up and let him go away. Can you find you?
Probably. Here we go. There you go. And start. This. There you go. Good morning. So, again, thank you so much for having me here. I always enjoy coming down and see a lot of familiar faces, and hopefully, as you guys know, prostate cancer comes in different shapes and sizes. There's so many, so many people have different experiences with prostate cancer. So there's many topics. Today we'll talk about one of the topics of prostate cancer, which is androgen deprivation therapy. I changed the title a little bit to talk, call this the androgen receptor makes a comeback. And there's a lot of reasons for that title, which we'll go into. See here. So this is actually my youngest patient. And he had radiation therapy. And so, but he's doing okay, yeah. All right. So the androgen receptor is the target of prostate cancer growth. And it is, it's cancer cells, they evolve over time by changing that receptor over time. And that's why cancer becomes resistant to traditional hormone deprivation. There's a lot of new drugs that are already on the market, which some of you guys are on. And there will be many new drugs actually targeting this receptor. We saw that there's some men in here who got chemotherapy. We're seeing now that there's going to be less and less men getting chemotherapy because of these new androgen receptor, anti-androgen treatments. Going back a little bit, just to give you guys a general overview of the topic. Some people call androgen deprivation therapy hormone blockade. Some people call it androgen suppression therapy. Some people call it testosterone inactivating pharmaceuticals. So how does androgen deprivation therapy work? Basically, if you guys look at this cartoon here, we'll start here. This is the prostate cancer cell, and we make testosterone or androgens mostly in the testicles and also in the adrenal glands. And these little testosterone or androgens is what feeds this cancer cell. Whoops. Okay, so and this is another schematic. Let's say this is the androgen or testosterone. What it does is it becomes attached to this little androgen receptor, and this complex gets taken into the nucleus of the cancer cell, and then it stimulates the DNA of the cancer cell to replicate. And as the DNA grows, the cell grows and replicates. So over time,
This down arrow works better if you like it.
perfect, thank you. So over time, these little cells become little tumors. They become bigger tumors. This is the prostate, by the way. And as the tumors grow even larger, it invades the area around the prostate, such as the seminal vesicles, the bladder, etc. And eventually, it can go into the bones. Okay. So this is one way we do androgen deprivation therapy. Okay. So I used to be a soccer player. But the more traditional ways to have androgen deprivation therapy or castration are the three that that I indicated here. The old-fashioned way would be doing the surgical removal of one's testicles, which it's pretty permanent. There is a medical way, which is to basically tell your testicles to stop making testosterone. And these are various types of injections with names such as Trelstar, Lupron, Zoladex, Firmagon. They medically castrate someone. And even over time, as we age, we go, almost every man, we make less and less testosterone over time. And now that it's become recognized that us men go through something called menopause. And it's not as dramatic as menopause, where it happens over a period of a year or so. In men, we make less and less testosterone starting around age 40, and it's a gradual process that occurs over decades. So when are some situations where we use androgen deprivation therapy? Well, for people who are newly diagnosed, especially men who have higher risk disease or men who are diagnosed later because they're not getting their PSAs checked, we end up needing to do androgen deprivation therapy to improve one's cure rate. Okay. Another situation is when a person undergoes radiation or surgery. Despite doing that treatment, the cancer comes back. And usually that's manifested by a PSA rise. And when the PSA rises, eventually that translates into visible cancer. So one way we treat the PSA is using androgen deprivation therapy. Of course, if cancer progresses more and becomes larger, androgen deprivation therapy can shrink visible cancer and improve symptoms. Okay. Full disclosure, using androgen deprivation therapy by itself, I'll say ADT, ADT by itself doesn't cure the patient. It could control the disease for years and decades, but by itself, it's not a treatment that cures people. So this is some data that I put together which showed that using androgen deprivation therapy in conjunction with radiation definitely improves outcomes and mostly survival. So the first study was over 12, 13 years ago when they showed that adding a long duration of androgen deprivation therapy to radiation, 3 years, improves survival for these very high-risk patients. these patients had a PSA, you know, anywhere between 50 and 100. And with 3 years of ADT plus radiation, there was a marked improvement in remission. They've done more studies basically using less and less duration of ADT, 6 months, 4 months, 4 months. And it all depends on so for when I see a patient, I have to help decide for them, you know, how long to use androgen deprivation therapy. So in general, if you have very high grade, high volume, fast growing cancer, you do need to be on longer treatment, anywhere between 18 and 24 months. If you have, let's say, a lot of cancer, but yet the cancer is not the aggressive type, or if you have a really aggressive type, but there's not that much of it, you may get away with 4 to 6 months, maybe 9 months of ADT. So what about ADT with surgery? Officially, we really don't use ADT prior to surgery. We don't use it after surgery. But occasionally, if we did surgery and they found cancer in the lymph nodes, there was a study showing that if you just gave people ADT for these patients, patients do live longer. What about with ADT and seeds? This is a little seed. Oftentimes, people who get seeds, they basically have not too much cancer. They have a lower grade, lower volume cancer. So usually, we don't need to give ADT to improve a good cure rate, okay? However, sometimes patients have a very large prostate. In that situation, we do need to shrink the prostate so the seed procedure is more feasible and less side effects. So the next message I wanted to convey is, yes, you get a treatment, and what happens if the cancer comes back or the PSA rises? You got to remember, it's not a death sentence, and you guys are all testament to that statement. After relapse, prostate cancer is very, very controllable. Now, these are the traditional other non-cancers that when they relapse, usually patients don't live too long, you know, anywhere between just a few months for kidney and pancreatic cancer to a couple of years, you know, with colon cancer relapse, okay? With prostate cancer, we're looking at, 100, 150 months, 200 months. The more treatments we have, patients after relapse are living, over 10 years, very, very commonly. So this is another just kind of a timeline giving you guys perspective of how long one can control the cancer. In fact, after surgery or radiation, and if one relapse, and one starts ADT, on average, ADT, not the onset of dying, but ADT not working, takes about 11 years. Okay. So this was a pretty big study a long time ago that basically showed that men who had relapse were started on ADT anywhere between a PSA of 0.2 to 3.0. So this was not studied for people who have a PSA of 10, for example, after relapse. So for these people, if you keep the cancer under control, meaning start ADT fairly soon, it looks like it takes about 11 years before ADT stops working. So in this situation, where there's relapse, to summarize, it's going to prolong survival. It will decrease cancer complications because you're keeping the cancer under control. You're not letting it go crazy and causing symptoms. Okay? But you do have to, be very judicious about when to implement ADT. Of course, if the cancer is already metastatic and the patient has symptoms related to the cancer, you should do ADT. But short of that, if the patient doesn't have visible metastatic disease, at what point does one do ADT? Well, some of the factors that help us decide when to start are as follows. If you have a high Gleason score, okay, meaning cancers that are very aggressive, who have the potential to become aggressive, we start ADT sooner. When the PSA change is very fast, called a short PSA doubling time, or a fast PSA velocity. So if the PSA changes fast, that's a marker that your cancer is the fast-growing type. So in general, you know, we don't want to start ADT too early, but we don't want to start it too late. I'm not going to say exactly, you know, what number, but we try to, you know, implement ADT anywhere between a PSA of 5 to 10. Okay. If you have aggressive, fast-growing cancer, we might implement it at around a PSA of 2 to 4. Okay. The reason why we don't just put everyone on ADT right after radiation or surgery relapse is all these potential side effects. Okay. And these side effects can include osteoporosis, anemia, hot flashes, loss of sex drive, penile shrinking, muscle loss, breast growth, depression, memory loss, tiredness, diarrhea, you know. All these are potential side effects. Now, not everyone gets every side effect, okay? So, however, those who do, you know, they're not happy campers, you know. Okay. So, that's where the concept of doing intermittent androgen deprivation therapy comes into play. So, intermittent treatment is basically on and off treatment. Therefore, you get your treatment, you knock the cancer down, you stop the treatment, the cancer will come back, you knock it back down. So this is intermittent therapy. Of course, just by logic, you could tell the patients will have treatment holidays, and that's going to improve one's quality of life. Less expensive, less side effects, it's less scary. You know, you tell a patient, well, you know, we're going to put you on ADT. However, once we knock the cancer down, we're going to take a break. And when the cancer rears its ugly head again, we'll put you back on it. It's as opposed to saying, well, the cancer's back, you're on ADT forever. Okay. And it's possible that by keeping the cancer under control and keeping the clones from replicating, you may even delay the onset where ADT stops working. Okay. So here, I'm going to go through just some studies showing or backing up what we just talked about. The first study was actually 12 years ago that was presented in this journal called Clinical Prostate Cancer. And this was not a big study, but this was a study that treated about 68 men. And half of these men had intermittent ADT. The other half had continuous ADT, so 33, 35. And look here, the average PSA for these men was 38. Okay, so they started kind of late, okay? So the goal of this study was to look for the time where androgen resistance, hormone resistance, castration resistance occurs. And so in this small study, the group that stayed on continuous ADT, hormone blockade, about a third of these men developed androgen, hormone refractory disease after 31 months. The intermittent group, only 3 out of 35 had hormone refractory disease. So at least we could say, you know, it shouldn't look worse, you know, but it might even be better in terms of delaying hormone resistance. This was a larger study presented 3 years later with 760 men that after they were treated with ADT, if their PSA dropped significantly to less than 4 or 80% less than the starting PSA, they were then randomized to an intermittent group and a continuous group, so about 300 per group. They followed these patients for about 4 years and 3 months, and there was no change in survival. So this was looking for survival, not hormone resistance, okay? This was a median follow-up. It wasn't a long-term follow-up, but it looked like at least for 4.5 years, intermittent was just as safe, okay? And of course, the intermittent group had a better quality of life. They did note that if men had a low PSA with ADT, and to me, 2 is not even that low, they were off treatment 80% of the time. So, for example, 2 months on, 8 months off, something like that, okay? Another study that was presented more recently in 2012, a larger, better study of 1,386 men. And these are all men who have relapse disease. They don't have metastatic disease. So remember this part right here, okay? And then they treated about 700 men in each group. And what they did was put people on 8 months of ADT, stopped treatment, when the PSA went back to 10 or above, they started ADT again. And what they found this was a longer follow-up, and they found that the survival between the two groups was the same, okay, about 9 years. Okay? And again, these patients mostly had a PSA around 10 before they went on ADT. Okay? The group that had intermittent ADT, hormone blockade, were on treatment 27% of the time. So just to kind of simplify, it's like 3 months on, 7 months off. Okay? And it took about 10 years before hormone resistance happened. Okay? Of note, a lot of these men died of non-cancerous causes. So got to remember, we do treat prostate cancer. We become obsessed with it, you and me. However, we also have to keep in mind that we all have other illnesses that we have to take care of, mainly the heart, and also other cancer screening. Okay. Finally, so this was a study presented last year, another very large study, 1,500 men. So these guys were sicker patients with more cancer. These guys had metastatic disease. Okay. So they were all treated with ADT for 7 months. And of the men who had a PSA of less than 4, they then separated these men into continuous or intermittent ADT. And they found that, interestingly enough, the group that had intermittent treatment might have had a slightly less survival. Now, this was not statistically significant, but it was a suggestion, okay? So, if you think about it, it might make some sense. You're dealing with guys with metastatic disease, and it might be harder to do intermittent treatment. And maybe when you do intermittent treatment, you're not treating knocking down enough cancers in time. Maybe these cancers do require continuous suppression, okay? So, but at least it's not dramatically different. But in general, for patients with metastatic disease, I do have less, I'm more inclined to do continuous based on, number one, that the patients already have, more disease, and number two, possibly intermittent might not be as good as continuous, okay? But you do have to balance that with quality of life, of course. Okay. So we just went over, continuous treatment with all the side effects, the pros and cons of intermittent treatment. Let's talk a little bit about anti-androgen monotherapy, which is what George referred to earlier, as basically taking Casodex, usually Casodex, by itself. And the concept is, rather than get rid of testosterone, let the patient have testosterone, but just block the receptor. So here's a whole list of studies which showed that there's some studies with anti-androgen monotherapy dating back to 1998. So this study showed that it seemed like it was equally safe and good compared to castration. Okay. This study showed that patients had less side effects, better bone density, less obesity, less tiredness, less hot flashes. The one side effect was anti-androgen therapy causes more breast growth. Okay. This study showed that if one didn't have Lupron or castration, adding anti-androgen monotherapy to radiation improved radiation outcomes. Okay. Interestingly, though, on the other hand, this study showed that while adding anti-androgen monotherapy did not help. So it's a weaker treatment, less side effects, but it may not, result in better overall outcomes. Probably not worse, though. Okay. So, of course, the take-home messages were the libido was more often maintained. There's less fatigue. Survival was not too different. Of note, though, when you're on anti-androgen monotherapy, when you take a treatment holiday, the holiday tends to be shorter. So I tell patients, whereas if you do traditional ADT, you do 1 year on, you get 2, 3, 4, 5 years off. With anti-androgen monotherapy, you do 1 year on, you get 1 year off. Okay. But we still use it in certain situations where patients have less aggressive disease. I really don't think their bones could handle more castration, where sexual function is very, very paramount to their quality of life. We may try anti-androgen monotherapy. Okay. So let's step back a little bit and look at the big picture again. We're going to slowly talk about what happens when ADT or anti-androgen monotherapy stops working. So traditionally, in the early years of a man's battle with prostate cancer, their cancer is castration sensitive. So the cells are sensitive to androgen deprivation therapy. Over time, though, especially with the more cancer you have, the higher grade cancer you have, the longer you're on ADT, eventually these cancer cells become resistant. And traditionally, when the cancer cells become resistant, we do other things such as backup androgen deprivation therapies called second-line therapy, immunotherapy, chemotherapy, etc. So these are some of the newer treatments in the last Taxotere, which is a chemotherapy, was approved about 13 years ago. But all these other 5 medicines were all approved within the last 5 years. So the first two, we're really going to talk about the first two because today's topic is related to androgen deprivation therapy, are Abiraterone and Enzalutamide, Zytiga, XTANDI. Chemotherapy options include Taxotere and a newer drug called Cabazitaxel called Jeftana. There's a newer bone-targeting agent called radium-223, alpha-radin, Xofigo. And of course, there's an immune treatment, the only immune treatment for prostate cancer, PREVAIL. So let's talk about Abiraterone, Zytiga, for a while. It turns out that this enzyme, CYP17, CYP17, is very important in testosterone production. Okay? And Abiraterone blocks this enzyme. So that's all you got to remember for this slide. Okay? So this is a picture version of this slide. Basically, these ugly-looking, turd-looking things here is the CYP17 enzyme. And these enzymes play the role in creating testosterone and DHEA to feed the androgen receptor, which feeds prostate cancer. Okay? So Abiraterone blocks this enzyme. Okay? So in the early studies, they found that, wow, blocking this enzyme really improved PSA, CAT scans, and bone scans. If you gave it to these patients before they had to go on chemotherapy, at least 75% of the men had a profound drop in their PSA. If you gave it to these men after chemotherapy, still half of these men had a nice response. And then they subsequently started these phase 3 studies in 2009 and 2010, which we'll go over, or completed these studies. Okay. So this is what we call a waterfall chart. Each bar here is a patient, okay? And this 0 is their baseline PSA. And these are what happens to their PSA once they're on Abiraterone before they go on chemotherapy. So a lot of these men had profound drops in their PSA. This red line is 50%, okay? So this is 25%. So a lot of men had profound drops in their PSA. There's some men who dropped their PSA by 99%. Okay? A small group of men, despite Abiraterone, their PSA went up. Okay? A smaller group, not a, still significant. Okay? And keep in mind, try to remember the concept of waterfall charts because we're going to show a few more through this talk. This appears less effective because these are men who had Taxotere, chemotherapy. So their cancer cells have evolved a little bit more already because they've been exposed to chemotherapy. So you're going to see less wonderful drops in PSA, relatively a little bit more men who did not respond to Abiraterone. Okay? But this was a case where a patient had liver metastases from Abiraterone, from prostate cancer, and they were put on Abiraterone, and the liver metastases disappears. Okay? Here and here. Okay? Okay, so the first study on Abiraterone was called, it's actually CB is Cougar Biotech. This is the original company that started it. The first phase 3 study was called the Cougar 301 study, where they put about 800 men on abiraterone, and they compared it to about 400 men who did not get abiraterone. Both groups got prednisone. Okay, prednisone is required for people on abiraterone. And they found that there was an improvement in survival. Okay, and as soon as they found the survival improvement, they stopped the study and they asked for FDA approval. Okay, the updated results from a couple of years ago was about 16 versus 11 months. About 38% of the men had a PSA drop who got abiraterone. Only 10% got the PSA drop who got placebo. Remember, probably prednisone even improved one's PSA in some men. It worked for about 11 months, and patients on this abiraterone lived for about a year and a half. Okay, and this was compared to 11 months. Okay. So abiraterone got approved for men who had chemotherapy. Okay. The next study was done called Cougar Biotech 302. This was just, all this data is finalized and presented just this month in Spain, actually. And they took men who did not have chemotherapy and put them on abiraterone, and they wanted to see what happened. They compared about 500 men who got abiraterone, 500 men who didn't, and their goal was to see how long before the cancer got worse or before one needed chemotherapy. And the secondary endpoints were how long it took before a patient needed narcotic pain medicines. So this is a little background. These patients, I got to thank Dr. Ryan from UCSF for these slides. This is a baseline characteristics of these patients. So these men had a PSA of 40, okay, before they got an abiraterone. So keep this in mind in terms of when you look at survival data. Even the survival data from the earlier trial, it was people had PSAs over 100. Okay, so we tend to start people on these newer medicines a little earlier in our practice. Okay, these men had an average PSA of about 40. Okay, a lot of them had cancer in the bones. A lot of them had more than 10 spots. Okay, and about 50% of these men had lymph node or liver or lung lesions as well. Okay, so they found that taking the abiraterone delayed progression, meaning the cancer getting worse, by about 8 months. So one stays on abiraterone for about 14 months before the cancer gets worse, okay, and might need chemotherapy. So it turned out that people who took abiraterone had about a 27-month delay before needing chemotherapy, okay, and compared to placebo, about 17 months. Okay, it delayed the need for narcotic use, like morphine and codeine, by about 10 months. Okay, the survival data is not mature yet, and apparently, there is a difference in survival. You got to remember, though, almost 50% of the placebo group eventually got abiraterone. So that's going to, negate the difference. It's going to make this difference seem. Imagine if the people did not take abiraterone. I think the survival difference would be quite a bit different. Okay. And so this is just wanted to show you. Subsequently, this is just another, showing you guys, 44% of the people eventually got abiraterone. Only about 20% of these people got Jevtana. A lot of these men end up getting docetaxel. Only 10% of these men got enzalutamide. And then only less than 5% of these men got radium, and less than 10% got Provenge. So that may also skew the survival data a little bit lower, because a lot of these men didn't even get all the up-to-date backup plans that we have. Okay. So abiraterone, overall, it's pretty well tolerated. But these are things we have to look out for, including high blood pressure, which can be treated, low potassium, which can be treated, leg swelling, which can be treated, liver enzyme abnormalities, not easily treatable. This is one reason we have to stop the drug. Okay? Fatigue, could be helped, but people do tend to be a little bit tired. And it actually, taking prednisone helps their fatigue. Okay? But some men cannot take prednisone for various reasons. One of the most common reasons for not being able to take prednisone is diabetes. So back to this drawing about how testosterone feeds or attaches to the receptor and stimulates the DNA leading to cancer replication, just to refresh your memory here. Okay. So what happens, how do these cancer cells become resistant, or how do they evolve in our body to become resistant to primary ADT, Lupron, castration, Castrate, et cetera? Well, we think these are some of the hypothetical hypotheses on why these cancer cells or how they evolve. One of them is these cancer cells, they start generating a lot of receptors. So many receptors that one is unable to block all of them. Okay? So this is called overexpression of the androgen receptor. Okay? They've also found that some of these receptors, they immediately bind to the DNA. They don't even need testosterone to bind to it to cause this cascade. Okay? So that's a mutation of the androgen receptor. Okay? Another possibility is these androgen receptors are able to be stimulated by other chemicals like sugar or insulin or whatever else is floating in our body. So it's another mutation of these receptors. They call it activation by non-androgens. Okay? And this is another method is something going on in the receptor, in the cell itself is able to stimulate the receptors. Okay? But the take-home message is this receptor misbehaves, and we have to attack this receptor. Okay? So this is how enzalutamide comes into play. Okay? So just to refresh your memory, Lupron, Zoladex, Firmagon, et cetera, and Zytiga, they take away the food for the cancer, okay? The testosterone, androgens. Enzalutamide works a little bit differently. Okay? So enzalutamide or XTANDI, number one, it blocks whatever testosterone one has in the body from attaching to the receptor. It also blocks this complex from going into the nucleus. Okay. Number three, it blocks it from interacting with the DNA. Okay. And so, of course, it does help in shrinking cancer. Okay. So the first study for enzalutamide was, again, in men who had chemotherapy. And the reason why they do these studies in these sicker patients after chemotherapy is one can get results faster and the drug gets approved earlier. So this was a large study called the AFFIRM trial, and they compared about 800 men who had enzalutamide versus 400 men who were given placebo. Okay. And again, they found a significant survival difference, 17 versus 14 months. Okay. Statistically very significant. Every month that this person was on the study, there was a 37% less chance of dying from cancer. Okay. This is a Kaplan-Meier survival curve. This is the dying of prostate cancer, risk of dying of prostate cancer, and basically this is the average here, 50%, and the XTANDI did prolong survival, and this was updated just a year and a half ago. Okay. So then they used, same question, what about enzalutamide before chemotherapy? And they did another very nice study of same breakdown, 1,200 men. And about 80% of the men had a PSA drop of about 80%. Again, it did delay the need for chemotherapy to about 28 months, okay, versus 11 months, okay. So if you have and remember, these men had a PSA of about 40 also. Okay. So if you have a PSA of 40, you have metastatic disease, and the doctor says you have chemo or you could take enzalutamide, and if you take enzalutamide, you don't need chemo for 28 months. That's the take-home message, okay? That's pretty good, right? So this was updated just a few months ago in the New England Journal, okay? So as a result of this trial, they were able to they did get the FDA to approve using enzalutamide for patients before chemo, okay? Survival data not enough deaths had occurred, so they can't really even tell you how long people lived, okay? But it seemed like it's going to be better than, it was better than people who took nothing, okay? So again, this is a time to having a change in a progression in their bone scans and CAT scans. So it took about 5 months before the CAT scans, the bone scans got worse in the people who took placebo, okay? That's pretty fast, you know, okay? People on enzalutamide, it took close to 20 months before there was a change in their bone scans, okay? Survival data is hard to tell the difference simply because it's, a lot of the placebo patients end up getting other treatments as well, okay? So enzalutamide also has some side effects, and these include hot flashes, tiredness, headaches, aches and pains. A lot of men, and especially guys in their 80s, when they take enzalutamide, they do complain that they seem a little more cloudy. Their memory doesn't seem as good. They're not as witty. You know? And so that tends to happen. They also, interestingly, they noted that a lot of guys had more, you know, bronchitis and flus and coughs and colds. Some men had tingling. This was the infamous side effect everyone talked about with seizures, but it's gonna pan out to be about 0.5%. Okay, the main side effect of enzalutamide and abiraterone is actually the costs. Okay, each one of these medications are about $6,000 to $8,000 per month. Okay, so get Plan D. Okay. All right. So one thing what about you know? And these cancer cells are very tricky critters. You know, now that these cancer cells have been exposed to abiraterone and enzalutamide, what's happening is these cancer cells are evolving, okay? And they're finding ways to escape the effectiveness of enzalutamide and abiraterone. And we don't know exactly, you know, there's probably 10 to 20 different mutations that occur, but the first mutation that was discovered this year was this mutation called the androgen receptor V7 splice variant, okay? So what happens is, after patients take abiraterone or enzalutamide, okay, they get this mutation indicated by the blue bars, okay? And once they get this mutation, the likelihood of having a PSA drop is extremely low. So all men who took abiraterone, who got the mutation, did not respond to enzalutamide. Not a lot of men, but you know, 6 out of 6 men who got the mutation, their PSA went up despite enzalutamide. Okay. If you had enzalutamide and you got the mutation, it's very unlikely that abiraterone is going to work, except for this one patient here. Okay. So 1 out of maybe 10 guys who get the mutation will have a response to abiraterone. So the take-home message is, once you've been exposed to one, the other one might not work, especially if we find that you have this splice variant. So how are we going to find a splice variant? Okay, that's the next step. So they are finding, there is a test available, okay, but it's only in a clinical trial setting, okay, to look for this splice variant. Because if one person took abiraterone and I did the test and they had the mutation, I might not waste my time and give them enzalutamide. We might have to go, directly to different treatment. And if they did not have the splice variant, it sure looks like there's a good chance enzalutamide would work. See that? The PSA drops. Okay. So this test is very important, and we're waiting for it to become developed. And also, now that we know this mutation, the academic centers and the drug companies are trying to find drugs that can target this mutation. So these would be the next generation enzalutamide and abiraterone. So at the end of the day, we're still trying to really target the androgen receptor for prostate cancer, early stage and even very late stage. And that's why I'm thinking that chemotherapy will have a less and less of a role. Okay. So a couple take-home messages. ADT does improve remission and cure rates and survival in very high-risk disease. ADT works for a long time. There are side effects that are often very manageable. One of the ways to manage it is do intermittent treatment. Another way to manage it is consider doing anti-androgen monotherapy for select cases. And of course, the next generation of medicines against the androgen receptor are on the market, a little expensive, but they're on the market. And hopefully there will be many new ones in the next 3 to 7 years coming out. Couple future directions I wanted to tell you guys about that they're studying. One is in a person who has relapsed, they're comparing enzalutamide versus Lupron. So of course, less side effects. We're going to see if this is going to be equal to this. Okay. If it is, then just forget. This is another way of anti-androgen monotherapy. Okay. They're combining. There's a big study combining these two. This is like super duper hormone blockade. Okay. Hot flashes. Another study is they're combining Zytiga immediately with Lupron in patients who are not resistant to Lupron yet. Okay, they're combining enzalutamide with this Prosvac. They're combining this new PARP inhibitor with Abiraterone. They're doing various combinations of these medications, Abiraterone or enzalutamide, or combining the two before surgery to see what happens. They're combining either one plus radiation to see if this is enough to improve radiation outcomes without Lupron. And these are some of the next generation androgen receptor modulators. Okay. So this is my other young patient. He had a prostatectomy. So anyway, on that note, I want to thank everyone for attending. And a while to take whatever questions you guys might have.
Okay, thank you, Dr. Lamb. Let's start over here, and then we'll move over there. Any questions over here, please?
I was wondering if there was any role for genomic testing in identifying what is the best kind of ADT.
I think eventually, yes. The problem is we don't know enough about the genes to, we're not even sure what genes do what yet. So we can't develop things against a gene until we know what the genes are doing. They are doing genetic testing for newly diagnosed men to give us a further idea of what kind of cancer they have. And that might tailor the aggressiveness or not aggressive approach to a newly diagnosed patient. But genetic testing it's not available yet for how to manage ADT.
Okay,
Or
in the back.
implement ADT.
What do you use as markers for when to take the next shot from Lupron after you're on a vacation or something like that?
Sure. So the question is, once one stops Lupron and they're on treatment holiday, when do you go back on Lupron? Is that your question?
Do you have any pinnacles
So,
in terms of PSA? Or
sure. So, in general, a way to look at it is the more aggressive the cancer, the earlier we go back on Lupron. Okay. The more cancer you have, the sooner you go back on Lupron. And that would be maybe a PSA between 2 and 5. Okay. Or a PSA that's going up quickly. Let's say the PSA is doubling every month and it went from 2 to 4 in 1 month. Is there a reason to wait 1 month? It's going to go up to 8 next month. So you might as well start ADT at 4, okay, and not let it go up to 8. Okay.
pay any attention to the readings on testosterone?
Well, the testosterone levels, we want to see how fast and what your testosterone level is off hormone therapy. There are some men who go on Lupron, and when we say let's take a Lupron holiday, their testosterone remains low. It's as if they're still on Lupron. Okay, so a lot of these men, their PSA remains low. But the scary thing is if the PSA starts going up, even though the testosterone is low. Okay.
Okay, question here.
How does metformin fit into the puzzle, and what kind of dosage are you looking at?
So metformin might have an anti-cancer effect. There's some observations that people on metformin have less aggressive cancer. So the concept of metformin is twofold. We think glucose might feed cancer. We also think insulin might feed cancer, okay? So by taking metformin, you lower the glucose and you actually lower one's insulin levels, okay? So we use metformin and we've seen it in about 1 out of 3, 1 out of 4 guys. When one takes metformin, their PSA dramatically slows down, okay? And the dosage we try to use is about 1,000 milligrams, okay? The main side effect that you keep an eye on is metformin can cause diarrhea, profound weight loss, which may not be bad, okay? And, some men might become hypoglycemic. Their sugars might drop too much and they might pass out. That's probably only about 1 or 2%. Okay.
Okay, there.
They have some new methods, experimental methods for identifying cancer through scans.
Yes.
And once the PSA reoccurs, would it be advantageous to use that in combination with radiation? In other words, how would that fit into anti-androgen?
So the concept of, I got a long spiel about this.
Okay.
Okay, so a lot of patients are basically their life is tied around the PSA. The number goes up, we get nervous, we try to bring the number down. But the number itself doesn't do anything physical to the patient. You're not going to die from a number. You're not going to have bone pain from a number. Okay, but it's very terrifying because, of course, it means that cancer is growing. Okay, so one could say, let's treat the cancer when we finally see it, and let's ignore the number, okay? Well, that might be too late, okay? On the other hand, you don't want to treat the cancer when it's at a PSA of 1.0 and went up to 1.1 a year later, So you got to balance when to start treatment because of side effects, okay? So to answer your question, if we can see the cancer earlier, we would treat the cancer, treat earlier, okay? And will seeing the cancer earlier change one's destiny per se, okay? And possibly it will. So that's where all these new scans come into play, okay? So the new scans such as, basically, the one that's readily available is a sodium fluoride nuclear bone scan, okay? Medicare pays for it. It's going to detect bone cancer sooner than the old-fashioned technetium-99 bone scan. So if you see it, you should go on treatment earlier, okay? And we might be able to target those lesions, okay? Same thing with carbon-11 PET scan, which Dr. Almeida at Phoenix runs, and Dr. Kwan at the Mayo Clinic, they have it. So those are very good at detecting soft tissue and bone lesions. Again, if you see a lesion, you can zap it. You might not need to go on androgen deprivation therapy. So there is a role for this. Will it necessarily change everyone's destiny? Should everyone go get it? Probably not. If my PSA was 0.5 this year and went up to 1.0 a year later, if I did the scan, it's probably not going to see anything. So it's a waste of time and energy. So one of the cutoffs we use for doing scans is the PSA level. There's a higher chance we'll see the cancer when the PSA is at least 1.5, 2.0, 2.5. Okay? There's a higher chance we'll see the cancer if the PSA is going up fast, and there's a higher chance we'll see the cancer if the Gleason score is high. Okay? So it's just a new, it might be helpful in maybe 30% of men. Okay? There might be a role in it.
Okay, here.
We're on ADT. Can estrogen supplementation be given to reduce hot flashes and improve bone health?
Yes, so there's a couple studies that show that people on ADT, if you take estrogen in the form of a patch, you're going to have much less hot flashes and bone loss. Women take estrogen patches for hot flashes and bones. So it turns out that estrogen patches work for men who are on ADT. The side effects of estrogen is there's a tiny risk of blood clots. Okay, blood clots in your legs, blood clots in your heart, strokes. The other more common side effect is breast growth on estrogen. So that's the downside.
Is there a study like a point by Dr. Q that would convince them that it's okay to use estrogen supplementation?
Just type in estrogen supplementation on ADT. And there are studies, yeah.
I have a question, and it's a question of the members here. How many are on Lupron or the equivalent and have what you might call serious side effects? Raise your hand. Hot flashes, severe fatigue, you're very concerned about quality of life. Okay, it's not as many as I have had a big problem with it, so that's why I went off. But everybody's different, so just curious about that.
I think you maybe asked the question incorrectly, because you said how many of you who are on Lupron have.
All right, good thing.
How about those of us who were on? I will raise.
All right. Okay, how many were on and got off because of that? Okay, see, there's a little bit more. But I'd like Gene to comment, because he's on Lupron, and he's looking great, and he feels good. What do you do, Gene?
You probably heard me say it before, and it's his fault, because he told me to get to the gym and start working out, which I didn't want to do. I now do 6 days a week, about an hour, 45 minutes a day. I don't have issues with the use of Lupron, and that's why.
Okay, another question here. Do you have a question?
I just wanted to mention that Megace helped me with hot flashes on Lupron.
Yes, so there's many medicines that help with hot flashes. Megace, estrogen, antidepressants, and my favorite one is actually gabapentin. So gabapentin is a neuropathy drug. It's a very old anti-seizure medicine, and it helps people sleep, gets rid of hot flashes in about 2/3 of the men. So, and it doesn't have the side effect of blood clots. So Megace causes blood clots in rare cases.
But I do have a question. You mentioned Zytiga and XTANDI. I think were the last ones that you were dealing with. And then you also mentioned briefly Provenge.
in order, 1, 2, 3, which do you recommend after a person has gotten past Castadex doesn't work and Lupron doesn't work? Which do you order of preference for?
So the question is enzalutamide or Zytiga, Abiraterone, or Provenge. Well, enzalutamide and Abiraterone, we don't really, it's a toss-up, okay? Yep. The question is when, the more important question is when should we incorporate Sapulacel, which is Provenge. I think the immune system still plays a role, and Provenge does work. It does prolong life. If the cancer is growing slowly and it's early stages of resistance, I would try to get in that Provenge right away. It's only 1 month of treatment. Okay. In some patients where I want to be a little bit more aggressive, the cancer is growing quickly, one can do XTANDI plus Provenge. Okay. They work differently and they don't impair the other. So.
Okay, question?
Does the baseline testosterone, like if a man has a very low testosterone level to begin with, make a difference in what ADT treatment you use?
Not really. It might give us patients who have a very low testosterone who have a bad cancer, not low like castrate levels, but low for the average male. Those men don't seem to respond as well to ADT because think of it this way, the cancer has got to where it was, evolved to where it was bad in a low testosterone situation. So it's already evolving before your official diagnosis and treatment. So for those men, you actually might want to be more aggressive, maybe treat ADT longer or add Abiraterone to the traditional ADT or even chemo. Yeah.
Okay, question over here. Yes.
If you use a monotherapy like Castadex, does that decrease the effectiveness of ADT later?
In rare cases, I actually do think, there's no free lunch in life. You want to use an easy treatment and to avoid Lupron, but some men are not very lucky. The easy treatment stops working, and then you say, oh, I still have Lupron. I'll just go on that, and I'll get 11 years of treatment. And it turns out Lupron only works for 6 months. And I've seen that enough times to tell patients, not everyone should do Castadex monotherapy. Select cases, and so you're selecting for the evolved cancer cells sooner by doing a less aggressive approach up front. So just got to be careful and monitor closely, and one could get an idea if Castadex is going to lead to early Lupron resistance.
Okay, question here.
Yeah, Gene mentioned in opening remarks about how important it is to get regular PSA screening, but neglected the DRE. I think he could add that as being a very important test because people with low PSA can still develop big tumors.
Yes,
Agree with that? I
agree. Yeah.
Let me just add a note. I've noticed that many urologists don't do a DRE nowadays. And in part because the patients don't appreciate it.
Digital rectal finger exam, yes. So, I mean, that's, and also primary care physicians are just, the ones who still do PSAs, they just, if the PSA is fine, they just skip the DRE, and that's not good either.
One more in this row.
So let's say you had radiation 3 or 4 years ago, and then you have noticed your PSA going up slowly, not dramatically, but slowly. Is the surefire way of determining if you have a recurrence a biopsy, MRI, CAT scan, a combination there of what? Let's say you're going to a common ordinary urologist, not a cancer specialist like yourself. Do you and your practitioner just say, well, let's see it, wait till it gets up to 50, or or do we jump into a biopsy, or
Sure. Okay, so the question is, how does one evaluate a rising PSA after treatment? So PSA,
Say after radiation.
sure, I'm going to generalize a little bit, okay? So after any treatment to the prostate. So you got to remember, PSA after the prostate has been treated, when it reaches, let's say 1.0, okay? We're going to say that there's cancer in the body, okay? If there's cancer here that's prostate origin, it makes PSA. So, PSA is made by cancer. It doesn't have to be made by cancer within the prostate. So, and a lot of guys didn't know that, okay? So when let's say a patient had a PSA of 5, then we ask ourselves, is the cancer coming from the prostate region? The local treatment didn't work? Or is there some cancer cells creating PSA outside the prostate region? Or both? Okay, that's the main question. The lower the PSA when one gets relapse, the more likely it's only in that area. Okay, so then we do tests to look for cancer in that area. MRIs, ultrasounds, biopsies, okay? The higher the PSA, the more likely that the cancer's out here. Let's say a person has a PSA of 50 and there's cancer out here. Does it matter if there's cancer here? No, okay? So, a lot of it depends on the level. Okay?
Let me just add a personal note. I had radiation and my PSA went low. It went 0.2 for 10 years. And I kept having a PSA. My doctor, my primary care doctor, when I asked him about it, he said it's low. Well, it went up to 0.7. That's not low after treatment. The old benchmark of 4 being kind of the decisive point, that's before treatment. After treatment, that goes to the decimal level.
All right.
And my doctor did not know that. So I waited 2 years thinking it was low. It went to 14. So there's a kicker in these things. And when it's in the decimals, that's still a critical, and you need to talk to your doctor about it. Okay?
On that point, if you've had radiation and have had hormone therapy, but you still have the gland and the normal tissue, how much normal tissue, and can it still produce PSA markers, and what would the timeline be of what's left?
Sure.
Good tissue. Okay.
So the larger your prostate before radiation, the higher the PSA you may have and still qualify as not relapsing. So if you have a lot of benign, if you had a big prostate before radiation, after radiation, you're still going to have a lot of benign PSA producing tissue in that area. So it could be as high as 0.7, 0.8. Okay? If you had a small prostate and you had radiation, you don't want your PSA above 0.2, 0.3. It also depends on whether or not the PSA is leveling off. As long as it levels off at 0.2, 0.5, 0.8, it's okay. The question is if it just keeps going up. Benign tissue tends to level off in the PSA. Cancer will keep going up.
Okay, question here.
If you've taken a Lupron or Castadex thing to shrink your prostate size and also to lower your PSA, and it's successful, we've been talking about healing with hormone treatments here today. But would there be any reason to go immediately into radiation after you had the Castrate and had the Lupron?
So the question is, can one just do ADT by itself, or should we transition into some sort of curative therapy? So, it depends on the person. If you want to go for long-term closure and you're okay with side effects of radiation, then you incorporate radiation to the ADT. Okay. If you have a lot of other illnesses and you're terrified of radiation side effects and you responded to ADT extremely well, you may say, well, I shrunk it enough, I may get 3, 5, 7 years before I have to worry about it. I'm going to skip the radiation and maybe I'll, have some other illnesses. This might be quiet for many years. And then you could maybe reincorporate radiation the next go around if it comes back too quickly.
But you do intermittent blockade.
Right. That's a possibility. It's not curative, but it could turn back the clock a long time.
In the back there.
Can you comment, I know we've been talking about like advanced disease. Can you comment if there's a role for ADT before or in place of the primary localized treatment?
So kind of in the same line as this other gentleman's question. So the question is, in lieu of surgery or radiation, anything direct at the prostate, can one just do ADT, right? Okay. It works. It will shrink down the cancer, and you could get years of peace, okay? But eventually, the cancer will start growing again. So ADT is a good way if you want to delay local treatment, okay? If you add local treatment to ADT, especially radiation, you'll get a higher, closure likelihood. So, some men, we counsel them, it's okay to do that. They want to wait for radiation to get better. They want to wait for better surgical techniques. They want to wait for the new proton beam machine to get warmed up and, new treatments. So let's safely contain the cancer for a few years, so that you could have better treatments later on. Or you could just shrink down the cancer and then have some, avoid side effects for a few years before doing local treatment.
Okay.
But, there's a big trend these days to use focal treatment now on recurrence. And I wondered if you had any opinion or feeling about at what point do you give up on the focal treatment and accept the fact you've got systemic degree of disease and move on to more aggressive treatments, systemic treatments?
So the question is focal therapy. Focal therapy is basically directing the treatment to a smaller portion of the prostate to minimize side effects. The other focal therapy is if you had, only 1 or 2 spots in the bones or the lymph nodes, you just zap those, again, to minimize side effects. It all depends on what your goal is and what your desire for closure is, If, let's say, you have your prostate here and your cancer's here, why do the whole prostate? Why not just focally treat that one side with ice or temporary seeds or HIFU? It's pretty effective at getting rid of the cancer on that side. But then you got to keep an eye on the other side. You're going to do active surveillance or, monitoring of the other side. Okay, so and you'll have less side effects. So focal therapy is promising, There's even patients who say, I have a lot of cancer here. I know I have a little bit of cancer here. I want to preserve my quality of life as much as I can. Just debulk, get rid of this side. I'll live with this Gleason 6 on the other side because it may take 20 years before it changes. So it is a promising approach.
Question that I have, you talked up at LA at the big conference about ADT light and ADT light. Do you want to comment some on that?
Oh, yeah. So ADT light is basically anti-androgen monotherapy. So a lot of the topics we went over. ADT light is for patients who don't have that much cancer and it's just growing slowly, why not just contain it? And that's where light occurs. And that's usually 5-alpha reductase blockade with finasteride or dutasteride. And so for patients, number one, who are on active surveillance, we put them on ADT light just to prolong the surveillance period. Let's say you need treatment in 10 years. By taking light, it might be 15 years, okay? If you have a PSA relapse after surgery and radiation, and the PSA is rising, ADT light slows down the PSA so that you don't need ADT light or Lupron, you know. So just another gentler way of controlling not that aggressive disease.
In other words, those are before you go to Lupron.
Yes.
Okay, another question here.
Is there a nominal target on holiday period that is preferred versus what your practice actually sees?
Okay, so is there a nominal PSA target for one?
Range of holiday period, I should say. The duration of time between ADT treatments, that holiday period.
Okay.
What is your nominal target and what do you actually see?
Okay, so you know, what determines a holiday duration is how bad the cancer is and if we see visible cancer. So the definition of how bad the cancer is how fast and how high the PSA is. And if we see visible cancer, during the holiday period we do scans, and if we see cancer, even if the PSA is low, holiday's over. If we don't see cancer and the PSA is kind of high, we may prolong the holiday, okay? So it's a balance of those two factors, the number and what we see. You know, the holiday could be anywhere between 1 year and 7 years, you know, 7, 8 years. Okay.
Okay, I have a question in the far back.
I had a comment and a question. One is that I had really bad hot flashes, and I started taking the gabapentin, and it really works well. I got just modest hot flashes, so if you have them, talk to your guy about it, because it really works. The question is, almost everybody's taking Castrate, which is the bilutamide, I guess?
Yeah, bicalutamide, yeah.
Okay, I'm taking the Landring, which is the glutamide. Is there any difference within that family, in your opinion?
So nilutamide or nilandron is a cousin of Castrate bicalutamide, and which was the go-to utamide before enzalutamide came out. So I commonly use that when Castrate bicalutamide loses its effect, and it works quite well. The only precaution is about half the men, they don't enjoy their alcohol anymore, okay? So that's a big factor. And a lot of men, when they go from a bright room to a dark area, their eyes don't adapt to the darkness very well, okay? The third thing is about 1 out of 100 men get some lung damage. And it usually occurs within the first 3 months. So if you're going to get it, you're going to get it within the first 3 months. So, and that could be permanent. So that's very important to kind of, your doctor needs to know that and listen to your lungs at least the first couple months.
Any other questions here? Okay, let's move over here. Yes, sir.
Yeah, when I was first diagnosed, I asked the doctor how long I would last if I did nothing, and he said maybe 1 to 2 years. I'm metastatic to the bone. And I said, how long is this Lupron going to help me if I take that? He said 1 to 2 years. Now, you suggested that lots of folks seem to go much longer than that, maybe 10 or 11 years. What fraction of the people get the 10 or 11 years?
Sure. So the more cancer you have, the shorter your life is going to be, okay? And the higher Gleason, the higher PSA, the more spots you see in the bones, the shorter the duration that Lupron will work. It could be as short as, 1 to 2 years, okay? Luckily, once Lupron stops working, we got 5 new things in the last few years to spread it out. So people still live years with metastatic disease, okay? On the other hand, if you have a tiny little bit of cancer and you put people on Lupron, it could work for 20 years, okay? But then you have Lupron side effects. So it's always a balance on when to start Lupron.
Question?
Yes, with something like an intermediate risk prostate cancer and the choice of radiation, you mentioned you could do ADT, it could be for a couple of years, it could be even last like 4 to 6 months.
Right.
Now, would Castrate alone be one of the possibilities, or is that?
Probably, it looks like the studies, the short answer is probably not enough studies to give you Castrate to try to improve your survival, okay? or make radiation work better. Okay. But you could do Castrate while you're deciding if you want to do radiation, for example. It will shrink the cancer down temporarily. So, but if you're doing radiation, I wouldn't do Castrate alone.
Okay, and that other choice, Castrate, kind of why you're thinking about it, do most health HMOs do that?
Yeah, I think so. I think you could talk your doctor into it.
Wow, okay.
Okay, we've got time for 2 more questions.
Thank you.
You could say, hey, I refuse radiation, even though you know you're going to make a decision, and then, but I don't want my cancer to grow. How about just giving me some Castrate for a while?
Okay.
Yes, 3 years after Rapidar, with a PSA nadir of 1.2 on a normal prostate. Is that good?
So Rapid Arc is a type of radiation therapy, and so in general, the lower the PSA after treatment, any treatment, radiation, surgery, ADT, the more likely you're going to be cured. Okay, so after radiation, I do like to see the PSA under 0.5. Okay, now there are exceptions where if you have a big prostate to begin with, you're not going to get as low as 0.5. Maybe 1 is the lowest you'll get, and you may still be in remission, but you just have to check frequently to make sure it's not the beginning of an upswing.
Okay, 1 more question over. Okay.
Does prostate size obviate any of the specific treatments?
Prostate size makes any treatment a little more difficult, but and the human size makes treatment it's a bigger factor than prostate size. So surgeons don't like to operate through a big level, thick adipose. Radiation, same thing.
Okay, some of you have not turned in your yellow forms. Please do that. Don't forget to sign a card for Lyle. I'll be down here, and you have any questions, let's thank Dr. Lamb for an excellent presentation.